speakers. We have Dr. J.C. Mohan, Chairman, Institute of Heart and Vascular Disorders, Jaipur Golden Hospital, New Delhi, ex-Director of Cardiac Sciences, Fortis Hospital, ex-Professor of Cardiology at GP Pant Hospital, and MA Medical College, New Delhi, and past President of Indian Academy of Echocardiography. We welcome Dr. J.C. Mohan.
Thank you.
We welcome Dr. Sumitu Ray, a professor at Vivekananda Institute of Medical Sciences, Kolkata, Senior Interventional Cardiologist at Woodlands Hospital and Sri Aurobindo Seva Kendra, Kolkata. We welcome Dr. Sumitu Ray.
Good evening.
Good evening, sir. We welcome Dr. Devdutt Chafikar, Consultant Nephrologist and Director, Supreme Kidney Care, Nasik, Consultant Nephrologist, Wockhardt Hospital and Sahyadri Hospital, Professor of Medicine, Dr. Vasant Pawar Medical College, Nasik. So we heartily welcome Dr. Devdutt Chafikar. We have an even cardiologist, Dr. Sadanand Shetty. We welcome him. The consultant cardiologist, Mumbai, professor and ex-HOD of medicine and cardiology at Dr. D.Y. Patil University, Nehru, earlier associated with KJ Somaiya Medical College. Then we have our international KOL, Dr. Professor Dr. Gregory Leap. He will be introduced in detail by Dr. Sumitu Ray in time to come. So he will be joining at 8:20 or 8:15, 8:20. He's a renowned speaker and from Liverpool, UK. From Macleods, I welcome Dr. Amit Kamra, GM Medical Head, Dr. Parth Sarthi, Medical Advisor, and Mr. Priyadarsan Soni, Marketing Head, Mr. Rajan from Marketing Team. Doctor, we can proudly say that Macleods pioneered moxonidil in India in the year 2009 and established the concept of effective yet safer option in difficult to treat hypertension, and since then is a brand leader in the category. With over a decade of Indian experience, we have set an objective for today's agenda as to assess current practices in diagnosis and management of resistant hypertension in India and use the experience and expertise of international KOL and esteemed panelists in updating clinical practices. Over to Dr. Kamra.
Thank you, Mahesh sir. And on behalf of Macleods Pharmaceutical, I once again welcome the esteemed faculty and our audience as well. And I hope that our today's webinar on resistant hypertension will help the clinicians in India to treat resistant hypertension effectively and improve the patient outcomes. I'll just take 2 minutes and introduce you to our organization, Macleods Pharmaceuticals Limited. So we all at Macleods Pharmaceuticals are committed to global quality, and we all are determined to excel. Our organization started in the year 1986 under the visionary leadership of Dr. Rajendra Agarwal, who currently is our managing director. Shri G.L. Bavri is our chairman, and Shri B.L. Bavri is our joint managing director. And during these years, we have gained special reputation because of our high growth rates, because of our quality manufacturing, and because of our economical pricing. And we are currently the 8th largest company in the Indian market. And amongst the generics of Vildagliptin, Vildamac is the #1 brand. And any pharmaceutical company, the strength lies in its manufacturing facilities. We have 5 well-equipped state-of-the-art manufacturing facilities at Bati, Daman, Sikkim, Saregram, and Indore. And Saregram plant is our mother plant, which fetches the APIs to the other plants. And together, we manufacture more than 700 products within our own facilities. And no pharmaceutical company can operate without a good research and development center. Our research and development center is situated at Mumbai at Andheri East. It's spread across an area of 3,500 square meters, and it is duly approved by the Department of Scientific and Industrial Research, Government of India, and it is supported by 700 scientists currently. Within our research and development facility, we also have our own bioequivalence center, which is a state-of-the-art 184-bedded center, which has been successfully inspected by the US FDA as well as the World Health Organization. And center has well-equipped pathological lab, emergency care unit, and bioanalytical sections. And during the last 5 years, we have carried out more than 80 clinical trials and 230 bioequivalent studies. Talking of our commercial operations are divided into 10 business units, and put together, we cover more than 2 lakh Indian doctors, and we are present across all the spectrum of the therapy areas. And we are blessed that we cover 200 Indian doctors. Talking of our global operations, in addition to India, our presence is felt in more than 80 countries worldwide, which also includes the developed as well as the developing markets. So to sum up, I can say that we all at McLeod's, we are committed to compassion and care, and we will continue to be the anecdote of improved living, and we together will do every bit to make the world a better place. With this, I would like to hand over to Dr. J.C. Mohan sir for his session on resistant hypertension. Sir, welcome.
Thank you, Amit. Good evening, friends, ladies and gentlemen. This is actually the introduction to this topic. I'm going to take 10 minutes explaining where lies the resistance when we are not able to get onto the goal treating hypertensive patients. The fourth National Family Health Survey, published just over 1 year back, and having representations from 27 different states of the country, shows that only 8% of all hypertensive individuals in this country are controlled. However, in case you look at treated versus control population, that is still heartening. 60% of all people who are treated are controlled and 40% are uncontrolled, according to this very latest data. Previous to that, we had meta-analysis of these 142 studies from India, and it showed that in urban area, control of blood pressure was 20%, and in rural area, it was 10%. And this is what we are talking about, the total hypertensive individuals. So these numbers are not very different from what is there in the National Health Survey, fourth National Health Survey. So the Government of India, Ministry of Health and Family Welfare, in a multi-partner project, starts with this slide, which shows that we have approximately 200 patients of hypertension, taking the older definition of 140/90 and above. 50 million of these individuals are treated, that is 25%, and blood pressure control is achieved in 20 million people, that is 10%. So 40% of all those who are being treated are controlled, according to Government of India data, and 10% of all hypertensive are controlled in this country. What are the reasons for suboptimal control, not reaching the goal? And we would not discuss the fact that the bar has been lowered now by a good number of guidelines, bringing it to 130/80 and below, which would obviously increase the number of suboptimal control. That is an issue which we can discuss in Q&A. However, the suboptimal control with standard definition, there are issues related to patients, related to medications, and a control system. The control system could be doctors at fault, nurses at fault, equipment, technique, hospital. Nevertheless, one thing is certain, that patient-related suboptimal blood pressure control accounts for nearly 56% of all suboptimal control. The reasons are non-compliance, knowledge deficits, medication cost, complicated regimens, side effects, poor physician-patient communication. Eventually, if you look at 1 year adherence to hypertension drug therapy, that is only 58%. 42% of the individuals discontinue drug a year after initiating antihypertensive drugs. There are many reasons where, despite drugs being taken in the amount prescribed, one would have difficulty in controlling hypertension, and these conditions are patient-related, but not in the control of the patient. For example, diabetes, chronic kidney disease, obesity, black race, and old age. Another thing which we have found that patients who have left ventricular hypertrophy, especially on ECG, are also difficult to control hypertensive individuals. So these are the phenotypes of difficult to control hypertension. Exogenous agents responsible for treatment failure probably account for 1%, but are overemphasized. Drugs like COX-2 inhibitor, NSAID, appetite suppressant, steroids, tea, coffee, alcohol, oral contraceptive, a lot of drugs have been blamed. These do play a role, but in general population, probably not very big role. However, in a specific patient, there can be big role of exogenous agents. Control system related suboptimal control. Well, white coat hypertension, where we doctors or nurses are probably hospital to be blamed, occurs in 1/3 of these individuals. Osler phenomena, which is of course a physiological phenomenon. Using actually R type of drugs or their combination V type patients, we of course have discussion on that. Suboptimal doses, using short acting drugs, not using loop diuretics when eGFR is less than 40. And of course, irrational fixed drug combinations or so-called inappropriate combinations. Exogenous agents we talked about, and inappropriate measurements, which are very important reason for 20% difficult to control. Actually, it's not a difficult to control. Something else should be labeled, and inappropriate measurements are not uncommon. We also have to keep in mind that we should be able to recognize the phenotype of hypertension, because even diuretics or calcium channel blockers can cause high pressure response in 5% and ACE inhibitor or beta blockers in about 10%. This is because people who are V type will respond to diuretics or CCB, and people who are R type or renin type will respond to ACE inhibitors or beta blockers. We can have more discussion, but this is just the initiation for 10 minutes. We wouldn't go in details. This is one of the most commonly used inappropriate combination, RAS inhibitors plus beta blockers, which could include an ARB or a beta blocker. Why this is inappropriate? Because similar mechanism of action, and beta blockers are pseudo antihypertensive, so you can't be calling it giving two drugs. And of course, volume dependent no renin hypertensive individuals may actually show pressure response in these individuals. So whenever you see a person difficult to control, you have to ask yourself, is it white coat hypertension? And of course, home blood pressure monitoring, repetitive home blood pressure monitoring, and ambulatory blood pressure monitoring have a role. And this needs to be done in every person who is difficult to control. The other causes of uncontrolled hypertension, of course, the commonest one is under-treatment. Actually, a lot of us have therapeutic inertia. We don't treat them well. Non-adherence is an issue. We have already discussed white coat hypertension and, of course, inaccurate blood pressure measurement. Coming on to the definition of resistant hypertension, the AHA 2018 said, and now this is a little different from the 2008 definition, which David Calhoun actually presided over. And it says uncontrolled with 3 drugs or different classes at maximum dose. It doesn't say the median dose, it says maximum dose. And controlled on 4 or more drugs is also resistant hypertension. So the resistant hypertension has 4 components. It is above the target blood pressure, which of course the target is a moving thing. It is a shifting sand at the moment. 3 or more drugs are different classes at maximum tolerated dose. Now that is the second point, which is different after excluding white coat hypertension and after excluding non-adherence. We also have 2 fundamentally different phenotypes: resistant hypertension, which is largely volume dependent; refractory hypertension, which is largely excess sympathetic nervous system dependent and would need central sympatholytic drugs like moxonidine, clonidine. On the other hand, volume dependent could behave well with diuretics and spironolactone. Some others have shown why people are difficult to control. CKD is important cause, black race, diabetes, obesity, coronary artery disease, cardiovascular disease, old age are some of the causes where you can have difficult to control. How do we evaluate patient who has resistant hypertension, difficult to control? We should have 24-hour ambulatory blood pressure monitoring for white coat hypertension. Home measurements again are required. A limited search for secondary causes should be made in every case where it is difficult to control, and logical combination should be used, and hemodynamic monitoring may be required in some. However, in general, if you really ask me, without going in all these details, three things are common causes of difficult to control: salt abuse, substance abuse, which includes alcohol, tea, coffee, and smoking, and of course, sleep disorder. And Dr. Soumitra raised here, he showed a beautiful case of sleep disorder some months back. So I'm pretty impressed by that kind of data. And I feel, remember these three S: salt, substance abuse, and sleep disorder. And these can cause tremendous amount of rise in blood pressure, which is difficult to control. Of course, you have to find out whether true resistance or pseudo resistance. ABPM helps, and of the 12-13% people who are truly resistant in the general population, 2/3 of the people are truly resistant, but 1/3 have pseudo resistance, or maybe 40% pseudo resistance, and that is because of the white coat hypertension. Dr. Chefeker will take us through the renal resistance, and I should not be digressing or transgressing into his field, but it is suffices to say that EGFR dictates response to treatment. As the EGFR decreases, chances of uncontrolled hypertension increase, and that is something which we need to keep in mind. And here are some of the situations where the drugs which we are going to discuss would be helpful, like moxinidil. We also have to understand that by and large, the difficult to control hypertension have low renin volume dependent hypertension, as shown from Birmingham study and from the Oslo study. The primary hyperaldosteronism is not uncommon. Actually, data as high as 20% has been shown in individuals difficult to control, bringing in the role of spironolactone or fourth-line therapy, also, of course, proven by the Pathway 2 study. But the primary aldosterone often masquerades as essential hypertension, and we need to actually keep that in mind. Need for diuretics can't be overemphasized, because occult expansion of intravascular volume is the single most important cause of drug failure, and we must bring in an appropriate diuretic depending upon the EGFR before we call the patient difficult to treat. Dr. Raymond Hermida, who has been working about the chronotherapy, suggests that if you change the same drug from morning to evening, at least one of the drugs, you could convert difficult to control hypertension to controlled hypertension. Another area of great interest and controversy, especially when HighRisk study shows so great benefits which people have started doubting. So what should be the approach in difficult to control hypertension? Exclude pseudo resistance, identify and reverse contributing lifestyle, discontinue or reduce interfering substances, screen for secondary hypertension, pharmacological treatment, which will be discussed in great detail by Dr. Gregory Lip, and referral to hypertension specialist. So let me summarize. Uncontrolled hypertension is not resistant hypertension. Let's not confuse the two things. Exclusion of pseudo resistance is important, implementation of lifestyle intervention is important, and discontinuation of interfering substances are important. You should also look for a sleep disorder. Work for secondary causes of resistant hypertension in limited number of cases, and referral to hypertension specialists may be required to improve the blood pressure control in nearly 50% of those difficult to control hypertensive individuals. Thank you very much. We will go on to Dr. Chefeker, who is going to talk about renal resistance, and that will make us understand why a good number of people have this issue and how to deal with it. And it also brings in the question, brings in focus the drug which we are going to discuss. Dr. Chefeker, please.
Thank you, Dr. Mohan. That was a great introduction to the topic, which covered many aspects of diagnosis and treatment of resistant hypertension. What I'm going to do is I'm going to talk to you regarding the renal aspects of hypertension. And we as nephrologists, we always encounter many patients who are very difficult to treat and they have resistant hypertension, because most of our patients would be on many drugs. And you know that most of our patients could be on 3 or 4 drugs. So let me bring to you the renal aspects of resistant hypertension. And I'm having some difficulty to share the screen.
Sir, you have to click on the share screen button. Can you see, sir?
Yeah, just hold on. Yeah.
Okay,
Yeah,
sir. Your screen
are
is
my
visible.
slides visible now? Okay.
Yes, sir.
Yes, sir. Yes.
Yeah. Yeah, just hold on. Yeah. So I think the definition of hypertension and resistant hypertension has already been alluded to, and I'm not going to repeat what has already been said. Now, just to give you some new information, Dr. Mohan already talked about what is the definition of resistant hypertension, and he has touched about some nuances of the definition also. But Dr. Bakris, who is a nephrologist working in the field of hypertension, gave us this information. Updated definition would be failure to reach goal blood pressure, which is the target is 130/80 as far as the nephrology community is concerned. But read the second line carefully. Despite adhering to full doses of an appropriate 3-drug antihypertensive regimen, which should include an appropriate diuretic for kidney function. Again, this was mentioned that it should be a loop diuretic if the GFR is on the lower side, a CCB and a RAS blocker, which is maximally dosed. Again, this has also been said. But besides that, there are some other things which we must look at before we declare that this is resistant hypertension. One is adherence with low sodium diet intake and medication. So adherence is one important thing. Good sleep quality. I think we alluded to sleep apnea as a cause of secondary hypertension, but good sleep quality, minimum 6 to 7 hours of uninterrupted sleep at night, also contributes to good quality of blood pressure control. Substitution of drugs with greater effect within the same class, that is ARBs and diuretics. That means you can substitute one ARB with some other ARB, of course maximally dosed, and then try and say whether it is still resistant. So you can substitute telmisartan with some other ARB and then say that this is still resistant. And of course, you must rule out all secondary causes of hypertension. What is specific about CKD? In CKD, it is a cause and effect relationship. So we know that hypertension causes CKD. Almost 30% of our CKD population could be blamed for having hypertension as a cause. However, we also know that with progressive fall in GFR and progressive CKD, the incidence of blood pressure, hypertension rises, and resistant hypertension also rises. And almost 70% of our resistant hypertensive patients will have CKD and vice versa. And we know that in healthy individuals, BP falls by 10 to 20% during sleep, but the dipping patterns are different in people with CKD, and they are relevant for the management of hypertension in CKD. So we have some resistant hypertension related to circadian rhythms of blood pressure in patients with CKD related to non-dipping. And the relationship between hypertension and CKD is complex, and therefore both cause and effect relationship is there. The magnitude is pretty high. One of the studies called a SEEK study, it said that almost 17.2% prevalence of CKD is there in the general population. And amongst that, almost 50% would be hypertensive and uncontrolled. Now, if you look at the etiology of hypertension in various causes of CKD, it is all throughout. That means you name the etiology of CKD and you have patients who have hypertension. So here you have diabetic nephropathy, chronic interstitial nephropathy, membranoproliferative glomerulonephritis, etc., etc. So all these are causes of CKD causing resistant or prevalent hypertension. This is an old study. It has also shown that if the systolic blood pressure was persistently high, more than 180, then it led to end-stage renal disease over a period of time, almost at the end of 15 years. So a very good correlation between uncontrolled blood pressure leading to end-stage renal disease as a cause. And similarly, a 17-year follow-up study has shown that uncontrolled blood pressure or severe hypertension is an independent risk factor for development of end-stage renal disease. This is a colorful slide, but just to tell you the physiology, this is a normal nephron. You can see the afferent and the efferent arteriole, the macula densa, and the proximal convoluted tubule. And you can see the mesangial matrix and the mesangial cells. And what basically happens is that whenever you have glomerular hypertension, then there is a glomerular barrier dysfunction resulting in proteinuria. You can see that the mesangial cells are now getting destroyed because of inflammation, endothelial dysfunction, as well as vascular smooth muscle proliferation. And functionally, you have fall in GFR, rise in proteinuria, expanded mesangial matrix, and glomerular sclerosis with tubulointerstitial fibrosis. This is a progressive nature of renal damage due to severe uncontrolled hypertension. And it's a vicious cycle. Rise in systemic hypertension would cause a rise in intraglomerular pressure, causes podocyte injury, causes proteinuria. It is also causes increase in the sympathetic nerve activity, and then followed by fall in GFR and sodium retention. And functionally, you can see that when there is nephron loss, also there is intrarenal ischemia, then again you have rise in sympathetic tone, which is self-proliferative, and then because of other causes like vascular stiffness, fluid overload, mineral and bone disorders, and sodium retention, ultimately all these contribute to resistant hypertension in people with chronic kidney disease. So what are the factors causing hypertension? Well-known factors would be sodium and volume excess, activation of the renin-angiotensin system, sympathetic hyperactivity, renovascular disease, and arterial stiffness. Some less well-recognized factors in patients with CKD, oxidative stress and mineral and bone disorders. Plausible factors again, hyperuricemia, sleep apnea, inflammatory cytokines, and drugs have already been mentioned. Sympathetic overactivity is something which is very, very common in patients with CKD, and it is found in early stages of CKD. There are several mechanisms by which you get sympathetic activation due to the activation of the neurohumoral pathways. And I will show you one slide later on how that occurs. So as far as the kidneys are concerned, the kidney is a source of central sympathetic drive in hypertension, heart failure, CKD, as well as ESRD. And we know that the efferent sympathetic activation, which is coming out from the brain, it causes rise in vasoconstriction, increase in the heart rate and contractility, and increase reduction in the renal blood flow as well as GFR. So there is something with a very interesting concept. There's something called as a reno-renal reflex. Now here what happens is that there is an afferent renal outflow from the kidneys, which is the sympathetic outflow. Now the afferent renal outflow, it goes to the brain and it has got a negative effect on the efferent renal outflow. This is called as the reno-renal reflex. Now, whenever there is damage to the kidney, whenever there is a fall in GFR, or whenever there is renal disease, you have this afferent signaling, but the efferent signal, which is coming from the brain, the efferent sympathetic outflow, is causing an excitatory effect. So basically, it has an excitatory effect on the kidney instead of an inhibitory effect. And then it has an effect on the heart, it has an effect on blood vessels, it has also an effect on the kidney itself, and that gives rise to all the effects which we see in resistant hypertension. And this is the real cause of resistant hypertension, the abnormal efferent sympathetic outflow from the brain, which has effect on the blood vessels as well as the kidney. And the concept of renal denervation came in resistant hypertension because of this particular phenomenon. And you can see that if there is a renal denervation, you are probably getting rid of the afferent, and then the efferent pathway also is affected because the afferent signals are not there to the brain. Now, there are some barriers for successful treatment, which are already been alluded to. Non-adherence is one cause, insufficient treatment, but there are some other medications, excessive salt intake, etc., has already been said. What are the targets of blood pressure? They are slightly lower. If you have proteinuria, the target should be lower. That's what the nephrology community feels, and proteinuria should be treated as a target in patients with hypertension. So if you have a patient with a proteinuria between 30 to 300, then the blood pressure should be again less than 130/80. If the proteinuria is not there, then you can be slightly liberal as far as your target is concerned. Of course, in diabetics, again, the target is the same, less than 130/80. There is some difference between the KDOQI guidelines followed by nephrologists versus the guidelines of the International Society of Nephrology. The KDOQI guidelines are slightly lower. How do you treat? There is an algorithm for it. First, you diagnose resistant hypertension, exclude pseudo-resistance, do the ABPM, and then talk about chronotherapy, and then always see whether there is a hyperactive RAS and optimize RAS blockade to the maximum. And if you have tachycardia, congestive heart failure, anxiety, these are clues for the excessive sympathetic overdrive. In that case, you can use sympatholytic drugs. Of course, you have to use optimize the diuretic regimen, which I have already said. This is an important slide. Now, you may have some issues associated with treatment resistance, and this should be the management consideration. If you have volume control as an issue and edema resolution is not there, then of course you need to use your diuretic judiciously. If heart rate control is inadequate, then you should use the right drugs. If the renin and aldosterone levels are low, then of course you can use a low salt diet, use amiloride, and avoid nighttime shift work for the simple reason that there's a difference between the renin and aldosterone levels in the night and during the day. If the renin is low and the aldosterone is normal or high normal, then you should use an MRA. If the splitting of medications is possible, then probably you can decide that on ambulatory blood pressure monitoring. If the adherence is questionable, then of course, then you can do discussion, or there are some studies to show that you can do urine levels of the metabolites of antihypertensive drugs and then find out what is the problem. If the pattern of BP response to medication outside the clinician visit time is unknown, then you try and probe the history into identify meal effects on blood pressure, the duration of medication effects, and the relationship of blood pressure to side effects using out of BP office monitoring. And if there is a sleep disorder, then of course you must initiate strategies accordingly, especially the non-drug strategies. So these could be some clinical clues and the treatment issues as far as treatment of resistant hypertension is concerned. So to summarize, there is a cause and effect relationship between hypertension and CKD. Blood pressure and eGFR are parameters which should be evaluated while screening hypertension. And as the eGFR falls, the blood pressure might be very difficult to control, becomes more resistant with progressive fall in GFR. And the blood pressure targets in patients with CKD, of course, they need to be individualized, but the target is less than 130/80. And you must think of sympathetic overactivity as an additional cause in all patients with CKD because it is pretty common and probably treatable. Thank you very much.
Thank you, Dr. Shafikar. I think that was a great overview of renal resistance in hypertension. And we would now go to an overview of resistant hypertension in India by Professor Soumitra Ray.
Thank you, Dr. Mohan, Dr. Shafikar, Dr. Shetty. Thanks to all, and big thanks to Dr. Amit Kamra also, who worked really hard over the last few weeks to make this program a success, and Team MacLeod, and of course I will welcome Dr. Gregory Lee when he will join. What I refreshed my understanding from the two great talks over last 20-25 minutes is that resistant hypertension is just a nomenclature. What we are actually dealing with is uncontrolled hypertension for various causes, starting from pseudo-hypertension to resistant hypertension and so on. What is the actual implication to a clinician and to the patient? I mean, all these theoretical discussions boil down to two main facts. Number one is that when we are having difficulty in controlling the pressure of my patient, we have to look for a secondary cause. Whether that is white coat hypertension, whether that is pseudo hypertension, whether that is patient non-compliance, or the basic 5 causes of secondary hypertension: renal parenchymal disease, renovascular disease, primary hyperaldosteronism, obesity and sleep disorder, and alcohol and substance abuse. This will solve 80 to 85% of your cases of so-called resistant hypertension, and you will get a clue. The second biggest implication in these patients is that you are losing time in controlling the pressure while the target organs are getting damaged. So you have to be aggressive. Not it is a matter of 2 drug, 3 drug, 4 drug, or 5 drug. Whatever be the means, you have to be extra aggressive with these patients to control the blood pressure very quickly to prevent the target organ damage. And then, of course, you can relax and de-escalate the doses when you are under control of the situation. So that is my understanding of resistant hypertension. I'll be very brief in presenting the very elegant study of Dr. Rajiv Gupta, which was published only 1.5 years ago in JAPI. Pattern of antihypertensive drug prescription in India, 3,000 patients. Very interestingly, ARB was 44% and ACE inhibitor was 13%. Together, RAS blockade was 61%. Very interestingly, I won't give any other adjective, very interestingly, beta blocker was 50%, whereas calcium channel blocker, DHP type, was 46%, and others are very less. Also, very interestingly, 2 drug was the most common pattern. 41% patients used 2 drugs. 1 drug is not less. About 1/3 of patients have got only 1 drug, which is against the recommendation by ESC, though ACC is a bit liberal on this. And 3 drug is about 20%. Now, with that regime and pattern of prescription, what is the prevalence of resistant hypertension? If we see by definition 1, and we are juggling with the definition over last 20 minutes, definition 1 is 3 drug, 1 is diuretic. That is the classical definition. More realistic definition nowadays given is prescription of any 4 drug with adequate doses. That is very important, or with the highest tolerated doses. I would use the term the maximum tolerated doses. And there, if you see from definition 1 to definition 2, the prevalence of resistant hypertension drastically falls if you use definition 2. That means if you use 4 drugs. So from 3 drug to 4 drug makes a huge difference. About 1/3 reduction of a resistant hypertension percentage from 20% to 6% just by adding 1 more drug. So you see, it is not, the definition is important how quickly you can control the medicine, whatever be the number of drugs required. And that is more emphatic with female patients rather than male patients. So as by the previous definition, 20% of hypertensives in India are resistant hypertension, and prevalence increases with age and with female gender, along with high baseline blood pressure, obesity, salt and alcohol, CKD, as we have already seen, type 2 diabetes, and LVH is a marker of resistant hypertension. If you see what are the common associates of resistant hypertension, particularly found in India, the first and foremost is diabetes, particularly HbA1c above 9%, CKD with creatinine above 1.5 milligram per TL, obstructive sleep apnea with apnea-hypopnea index more than 20, that is severe sleep apnea, and LVH and obesity with BMI more than 30. So if we address these few issues in a patient who is difficult to control his blood pressure, we might find the cause and might get a way out straight away. Now, problem of resistant hypertension is sometimes we find also that with age particularly, your systolic blood pressure is high and diastolic is low. And the question comes again and again in the mind of the clinicians, while aggressively reducing the systolic blood pressure, my diastolic blood pressure is going down to 50, 55. what would I do? What about the J curve? Now, J curve is controversial. J curve may be theoretical. It may be only limited to John Cruikshank and his group. So I say J for John Cruikshank. But very recently, only last week, there's a huge paper published from Boston showing that diastolic pressure going down does not harm you while attempting to reduce systolic blood pressure. So go all out to reduce the systolic blood pressure, even if your diastolic goes down. Only if there is an ongoing ischemia or unstable angina, then be a bit careful. Otherwise, don't bother. So I finish my talk very shortly to put you in perspective. And I introduce Dr. Gregory Leap. Is Dr. Gregory Leap with us? Has he joined?
Yes, sir. Yes, sir.
That's great.
He's there. He's there.
Yes, Dr. Leap. It's a typical British tea time, around 4 o'clock there, isn't it? So
yes,
you are
indeed.
having a cup of tea with us, and he's from the great city of Liverpool. You know, the city of Beatles and the city of the two birds, Bati and Bella. So Dr. Leap is MDA first CPF. He has got fellowship for your information from all the 3 Royal Colleges of UK. And he's also fellow of American College of Cardiology, European Society of Cardiology, and European Heart Rhythm Association. He's Price Evans Chair of Cardiovascular Medicine at the University of Liverpool, National Institute of Health Research Senior Investigator. He's a distinguished professor in Aalborg University in Denmark, an adjunct professor in Yonsei University in Seoul, and adjunct professor in Seoul National University. With that, I welcome Dr. Gregory Leap to give his deliberation on different aspects of hypertension as applicable to international, to European, and to Indian perspective. Dr. Leap, please.
Thank you. Thank you, Dr. Ray, for that very kind introduction. So let me share my screen and just get this right. Excellent. So firstly, thank you very much for the very kind invitation to join this webinar discussion. And it's a great pleasure. And also just to you know, in these difficult days, also in India with the pandemic, and well, very much hope everyone is safe and keeping well. Now, I've been asked to address particularly one of the advances in hypertension management, and I'm going to focus a lot on the guidelines, and practicing in the UK and Europe, I'll focus very much on European guidelines, and I'll try and explain why. Well, I'm a little bit biased, but why I think it makes sense. Furthermore, I've been asked to also cover some of the data for moxonidine, centrally acting, antihypertensive, but colleagues have done an elegant presentation with regard to the associated pathophysiology, also with regard to some of the epidemiology and prescribing habits in India, and hopefully which already puts the context with regard to why add-on drugs like moxonidine have a role, particularly in reaching blood pressure targets, especially in resistant hypertension. So just to start off with regard to the European guidelines for the management of hypertension. Now, if you notice, these are the current definitions. As you can see, in the European guidelines, you see normal for systolic blood pressures 120 to 129, high normal is 130 to 139. Now, think about the shift, the paradigm shift here, because if you look at hypertension guidelines from about 2 decades ago, what was regarded as abnormal was systolic blood pressures of over 160. So you can see that the goalposts have shifted. Therefore, to reach blood pressure targets to be optimized, we are all going to require more and more antihypertensive drugs. And one of the earlier presentations made this point. About a good third of patients will require 2 drugs, and then another third will require more than 2 drugs just to at least reach anywhere near those kind of targets to reach normal or high normal blood pressure. And of course, beyond that, there's the so-called grade 1 and grade 2 and grade 3. Now, these are arbitrary because we know that cardiovascular risk is and hypertension is a continuous variable. It's not, patients don't fall into 3 little neat categories that they are grade 1 hypertension today. So that's their diagnosis. And of course, somebody whose blood pressure is 140 systolic and somebody whose blood pressure is 159 systolic, well, they are still called grade 1 hypertension, but the magnitude of difference of risk by the nearly 20 millimeters in blood pressure difference is clearly going to be much higher. Now, ditto for diastolic, again, I'm not going to elaborate, but blood pressure and cardiovascular risk or stroke risk is a continuum of risk. And we tend to look at the risk factor in isolation because, but reality, of course, that doesn't exist. Many hypertension patients also have, for example, coronary disease. They may well have renal failure, as highlighted by one of the earlier presentations. They may well have associated target organ damage. And target organ damage clearly indicates that these patients are at particularly high risk because of uncontrolled blood pressure, whether we sort of include that definition of resistant or not. Because of uncontrolled blood pressure, they've either got end organ damage, whether it's manifest from eye changes, whether cerebral changes, particularly stroke, cardiac changes, left ventricular hypertrophy probably is the most common manifestation of target organ damage. But of course, associated coronary artery disease, renal failure has been discussed. And ultimately, you will see that the guidelines do talk about 10-year cardiovascular risk categories, and they recommend the SCORE system. Now, the SCORE system is interesting because, yes, it's been derived by and particularly validated in European countries, but of course, it also has the capability to be individualized for particular regions of Europe with regard to the score. So rather than say the Framingham risk score in the European guidelines, risk categorization is based on the score. And in terms of between low risk and very high risk is what I just mentioned, associated target organ damage, things like clinically manifest cardiovascular disease, whether it's clinical or imaging, diabetes, kidney disease, and obviously the calculated score puts these patients in the particularly high risk group of patients. Now, to go into detail, what guidelines say can make really boring as a very boring lecture, but I think suffice that the take-home message from what really guidelines say is if you have uncontrolled blood pressure, and you should be aiming to treat, to target, and that's what the European guidelines say. Because basically, as I showed on one of my first slides, what is controlled or what is uncontrolled blood pressure, the first objective really is to try and get blood pressures to under 140 over 90. And ideally, especially in the younger patients, even aim to 130 over systolic blood pressure on average for most of the patients. And in those who are more elderly, you might, rather than get too aggressive to under 130, blood pressures around 130 to 140 seem also appropriate. And these targets are not, if you want guidelines adherence, you keep the message simple. So generally, for most of the patients, you aim for basically under 140. And if you particularly have younger patients or patients with associated target organ damage that I mentioned on the preceding slide, you should be aiming for systolic blood pressures around 130. And that keeps it simple. General practitioners love simplicity, and that's when they're going to be able to be compliant with the guidelines. Blood pressures, ideally, diastolic blood pressure under 180 should be what's target. Now, these are targets of blood pressure, but can I emphasize again that we're not just focusing on managing blood pressure, we manage the whole patient, not just a bit of the patient, and this includes lifestyle type changes, salt restriction, alcohol restriction, body weight control, and managing obesity, regular exercise, smoking cessation, looking for other correctable conditions such as obstructive sleep apnea. And in terms of the regimes for treating, the message again is to keep it simple. And I think this is also flagged up by preceding speakers. Now, the core drug treatment strategy here if you think about initial therapy, ACE or ARB, ACE or ARB plus calcium channel blocker or diuretic. In patients only who have mild hypertension, clearly monotherapy is fine, but very likely dual therapy is needed just to reach the blood pressure targets that I mentioned earlier. Now, in terms of combination, what makes sense is ACE or ARB plus calcium blocker plus a diuretic. And then you're getting to stage 3. This is where it becomes like resistant hypertension, because you then require addition of other drugs, such as spironolactone, other diuretics, calcium blockers, other alpha blockers, beta blockers, and also ancillary agents, centrally acting drugs, etc. But in a patient where the non-specialist or general practitioner is struggling to control the blood pressure, I think it's really important by that stage to refer to the local hypertension clinic for further investigations and further evaluation. Now, beta blockers have been subject to lots of discussion whether it's appropriate as a first-line drug or therapy. My preference is not necessarily to put it as a first-line agent, because my first-line agents are either ACE or ARB, especially in those age under 65, and then calcium blocker diuretic, especially in the elderly, particularly before Liverpool, I was in Birmingham, and there was a large number of Afro-Caribbean hypertensives in my clinic. Therefore, calcium blockers or diuretics were appropriate. Beta blockers, however, there may well be specific indications for their use, heart failure, for example, coronary disease, or atrial fibrillation. And at the end of the day, very often patients will require more than one drug just to reach the targets that we've been talking about. Now, that's the core treatment strategy. And if you want to adapt that core treatment strategy, that obviously depends on what the underlying comorbidities are. And remember, this and the next few slides, when you're talking about associated comorbidities, we're really getting into the realm where there's some evidence of hypertensive target organ damage. And in this particular slide, this is coronary artery disease. And in a sense, that it's an adaptation of the core treatments that we talk about, but you see now beta blockers get into the initial strategy. And the initial treatment strategy, there's also very much a push in the European guidelines to be more popular use of combination drugs, because recognizing, again, rather than getting the patient having multiple bottles of blood pressure tablets in different bottles, use some of the fixed dose combinations and try and use that as part of the optimization, given that most patients to get blood pressure in will require 2 or more drugs. Here we have step 2, triple combination. Remember that in the presence of coronary disease or such as myocardial infarction, etc., they're high-risk patients. You really should be aiming for systolic blood pressure nearer 130 to achieve control. And of course, the resistant group, again, as we discussed on the preceding slide, an appropriate referral to the specialist as needed. Now, chronic kidney disease has been nicely presented by one of the earlier speakers. And you see here in the ESC guideline, this is the algorithm now, ACE or ARB plus calcium channel blocker, or ACE or ARB plus a diuretic as the initial starting. Here in triple combination, ACE or ARB plus calcium blocker plus diuretic. And then finally, we have the resistant hypertension group again, and really refer to your local nephrologist or your local hypertension service with regard to managing these patients. Now, don't panic in a sense that in the initial treatment period, there may well be a reduction in eGFR and a rise of serum creatinine, especially with an ACE or ARB. But don't panic with a small change. If the serum creatinine changes more than 30%, maybe it's worth further detailed evaluation for underlying renal vascular disease. So again, optimize and individualize your treatment because ultimately, in the presence of hypertension plus CKD, chronic kidney disease, that's again a high-risk category of patients. If you're not getting to blood pressure control, seek specialist attention or refer to your local nephrologist for further input. And for the sake of completeness, I'm just going to mention briefly two other high-risk groups: hypertension with heart failure with reduced ejection fraction. So here's ACE-ARB plus a diuretic, and of course with a beta blocker, and where a beta blocker in the absence of atrial fibrillation, so it's with patient heart failure, has been shown to have a prognostic advantage on mortality and hospitalization. And step 2 is a beta blocker and a mineralocorticoid receptor antagonist such as spironolactone or eplerenone, again in addition in combination, aiming again for blood pressure targets nearer 130. In atrial fibrillation, you need very often, apart from anticoagulation, blood pressure on a population basis is the commonest reason why these patients get atrial fibrillation, and therefore heart rate control to help symptom management is one of the important aspects of the management. So blood pressure control, the same, modifying the core algorithm as I showed earlier, but this time considering quite early on a non-dihydropyridine calcium channel blocker, in other words, verapamil or diltiazem, or a beta blocker as an alternative. Now, you obviously don't combine a beta blocker plus a non-dihydropyridine calcium channel blocker such as verapamil or diltiazem, because this may result in significant bradyarrhythmias. But in patients with atrial fibrillation, some of our own work has published that the optimal target for blood pressure in relation to reduction in stroke and myocardial infarction and heart failure and hospitalizations and mortality is to aim for a systolic blood pressure 120 to 130 and diastolic under 80. And that makes sense because in the European guidelines, atrial fibrillation is regarded as one of the manifestations of hypertensive target organ damage. So that's a run through the algorithms in the European guidelines, but this can really again be summed up as I mentioned. I showed the core treatment aspects, ACE or ARB plus then calcium blocker or diuretics initially. But for most hypertension patients in the general hypertension clinic, maybe under 140/85, but if there's evidence of target organ damage, like as I've described, coronary disease, kidney disease, heart failure, or atrial fibrillation, diabetes, we should be aiming for 130/80 as the target blood pressure. So that's essentially to re-emphasize the office blood pressure target ranges there. And by and large, as you can see, presence of younger patients there, diabetes, kidney disease, coronary disease, stroke as another manifestation of target organ damage. By and large, for most of the patients, aiming to 130 as your target blood pressure. If you're a bit older, well, even if you get to blood pressures of under 140, at least you're doing some good there. So that's the targets of blood pressure. Now, much has been talked about in earlier presentations about definitions and what is resistant hypertension and the associated causes with resistant hypertension. And I thought it would be probably worth to give you the European perspective of this, because resistant hypertension is defined as resistance to treatment when the recommended treatment strategy fails to lower office systolic and diastolic blood pressure under 140 or under 90, respectively. There is still inadequate control of blood pressure as confirmed by an ABPM or home blood pressure monitoring, where the patients whose adherence to treatment has been confirmed. So that's the definition of resistant hypertension used in the European guidelines. And some of the underlying reasons for so-called resistant hypertension when blood pressures are not reaching target have been highlighted by earlier presenters. And that includes things such as secondary hypertension, and there are common ones such as adrenal aldosteronism, renal vascular disease, sleep apnea. In my clinic, I routinely ask patients for symptoms suggestive of sleep apnea, and where appropriate, get a formal sleep study. Chronic kidney disease was discussed earlier, but of course there are more unusual reasons, whether it's things like pheochromocytoma, fibromuscular dysplasia, aortic coarctation, Cushing's, and of course hyperparathyroidism. There are, of course, drugs that can be associated with raised blood pressure, things like contraceptives, sympathomimetics, even non-steroidals, and some of these other drugs. And I think in younger hypertensives and in the Liverpool Hypertension Clinic, we seem to get a much younger cohort compared to what we saw in Birmingham. And of course, you look for any other interesting substances in regard to, in the young patient presenting. But the characteristics are worthy of discussion. Older age, obesity, more common in Afro-Caribbeans, salt intake, high baseline blood pressure, and chronicity, and very often have these manifestations of hypertensive target organ damage that we briefly touched on earlier, because these are patients that the blood pressure has been challenging to control, and therefore the brain, the heart, the kidneys, the eyes all sustain what essentially is target organ damage. And I already mentioned atrial fibrillation, another manifestation of target organ damage. Now, if you actually exclude the secondary causes, and I think again, an earlier presentation from Indian data suggests, and this is consistent, the actual true resistant hypertension prevalence is about is less than 10% of treated patients. And of course, this includes making sure that the patient actually is adherent and persistent to their treatment strategy that is agreed. So that's the resistant hypertension patients. And in terms of the management, again, is to make sure that you're making sensible combinations of treatment. And this is basically the algorithms that we talked about before. Make sure that there is confirmation of the diagnosis with an ambulatory blood pressure monitor. Make sure that the pseudo-resistant hypertension is excluded, especially with poor medication adherence and secondary hypertension. And a number of clinics up and down, especially in the UK, is actually checking for adherence, spot checks for adherence by taking a urine sample, and the lab providing evidence whether or not the patient actually has been adherent to their drug regime. But we may well focus a lot on the drug regimes, but don't forget the lifestyle type changes, sensible additions of second line and third line and fourth line and fifth line drugs, and making sure that the patient actually is adherent and compliant to treatment. Which brings us to moxonidine, because it's a centrally acting antihypertensive drug, and it's a drug which has been around for a little while. And in terms of centrally acting drugs, my understanding, quite popular in India, is clonidine. And this is a study, a crossover comparison of moxonidine and clonidine in mild to moderate hypertension. And as you can see, both the molecules do look fairly similar to each other, and they are centrally acting agent, that they stimulate central alpha-2 adrenal receptors. And as you can see by the introduction of moxonidine, that's the hash bars, or clonidine in the black bars, you see the reduction in blood pressure broadly similar. But after the discontinuation, this is how this study was designed. You see with moxonidine, there's a slower post discontinuation rise compared to clonidine, which is pretty short acting, and the blood pressure zooms up to abnormal pretty quickly. But the issue is here. Clonidine side effects are substantially higher. Sorry, here we are, 85% compared to those on moxonidine. So moxonidine much better tolerated compared to patients on clonidine. So if you have the opportunity to try and get a better add-on drug for, which is working the same way with less side effects, surely that's the appropriate thing we should be doing as doctors, and not subjecting patients to more side effects, but achieving the the broadly similar add-on effect of blood pressure reduction. In terms of the evidence for moxonidine, is there? This is a nice overview of the moxonidine efficacy in essential hypertension. And I'm not going to go through all the studies. I'll pick up some selected ones in the later part of my presentation. And this slide, this table is where they are placebo controlled. And I think if you're using a pretty rough guide for dose reaching target, and we're talking about diastolic blood pressure of under 90, you'll find that compared to placebo, obviously placebo, very few patients reach target, but moxonidine and thiazide about the same. If you add both together, you get additive, and even more patients are reaching targets. So 88% reach diastolic blood pressures of under 90 compared to individual therapies by the combination moxonidine plus a diuretic, in this case hydrochlorothiazide. Now, this is a separate study which looked at moxonidine and enalapril and placebo, and you find that here, as you can see, if anything, moxonidine was doing better than low-dose enalapril compared to placebo in terms of reaching target. Here's a separate study, moxonidine, enalapril, and versus placebo. In this particular study, moxonidine and enalapril reaching the percentage reaching target is broadly similar as single drugs. And ditto in this last study here. This is, of course, the baseline agents. These are uncontrolled very clearly, and the fact that you can get to controlled even in some of these placebo-controlled studies in a decent proportion of patients, single drugs, even better with combination drugs. What about where there's active comparator with moxonidine? So, and again, there's quite a number of studies, and I think in the interest of time, I'm not going to read every one, but you will see here for moxonidine and atenolol, 65–70% reach blood pressure targets. Or at baseline, they're all in the uncontrolled range. Moxonidine and enalapril here, and this is enalapril going up to the higher dose. It's not about 29% versus 45%. And in terms of moxonidine and calcium blocker, is again in the same ballpark figure as well. So it's useful as add-on therapies, particularly when you're trying to reach target blood pressure. Now, this is a study where this is studies showing the impact of combination drugs. And I highlighted earlier in my talk that these days, if you want to reach to blood pressure targets, almost certainly you will need add-on, you will need extra medicines to achieve the blood pressure targets, to make sure that those at high risk are getting to blood pressure control. So in this study, this is moxonidine plus amlodipine, this is moxonidine plus enalapril, this is moxonidine plus hydrochlorothiazide. In light green are systolic blood pressures, dark green are diastolic. You see the best effect is probably with combining moxonidine with a calcium channel blocker, and of course with followed by enalapril. This is placebo, this is hydrochlorothiazide, this is moxonidine, and this is combination moxonidine plus hydrochlorothiazide. And I think you can see in this particular study the additive effect by combining moxonidine with hydrochlorothiazide 25. Now, study A only at hydrochlorothiazide 12.5. But you see with the higher doses of hydrochlorothiazide, this additive benefit. In terms of study C is comparing moxonidine versus metoprolol as add-on therapies, and you will see the comparability there rather than a beta blocker with metoprolol. Patients actually do well in terms of blood pressure control or blood pressure reduction with moxonidine. And this is relevant, especially there are some patients who cannot tolerate a beta blocker, whether due to asthma or tiredness, and you have a good option for add-on treatment again. Now, it's not as if there's no drug in the world without small risk of side effects. That's the same for moxonidine. This is an overview again of the the clinical experience with moxonidine, and by and large is well tolerated. You see, so light green is moxonidine, dark green is enalapril, and then that's placebo. By and large, most of the more common side effects are not really that low percentages and not that much different to either a drug like enalapril or placebo. The exception is dry mouth. Dry mouth seems to be a common side effect with moxonidine, and that we expect from centrally acting antihypertensive drugs, because you sort of see that with clonidine as well. So tolerability is good and comparable to some of the other mainstay antihypertensive drugs like enalapril or rather ACE inhibitors or placebo, the exception being dry mouth. Now, I mentioned earlier quite a lot how moxonidine compares with regard to an ACE inhibitor, and in this case is enalapril 10 milligrams. And I think this is placebo, hardly any change and hardly any shift in blood pressure. But if you look at the moxonidine treated patients, you look at the enalapril treated patients for systolic and diastolic blood pressure, about the same reductions overall. Quite interesting, of course, is if you look through the time course here, you could almost superimpose the curves for moxonidine and enalapril on top of each other. So I think it's again another illustration why it's a good drug as part of a strategy of combination therapy to treat resistant hypertension patients. Now, this is the detail of the diuretic study I mentioned. This is placebo, a small drop with placebo. This is moxonidine monotherapy. This is hydrochlorothiazide. And with a combination, you see this additive benefit here. So put this into context with regard to resistant hypertension. And I showed this slide earlier, but I just want to flag up what's the common associates of resistant hypertension in our everyday practice. Older age, obesity, evidence of target organ damage, things like diabetes particularly, and evidence of vascular disease. And maybe this is one area where actually moxonidine has some interesting data. This is a study of moxonidine in obese hypertensive patients, and it's a comparison of moxonidine and amlodipine. And what you actually get is this is systolic blood pressure, this is diastolic blood pressure. Actually, there is comparable reductions in both systolic and diastolic blood pressure with both antihypertensive drugs. But this particular study was also interesting because the investigators look at moxonidine impact on sympathetic nervous activity, insulin resistance, and leptin levels in these obese patients. And there were benefits seen with moxonidine, not amlodipine. So you might the groups where there's associates pathophysiologically with resistant hypertension, obesity, for example, where despite comparable blood pressure reduction, moxonidine seems to have this benefit on reducing sympathetic nervous activity and then on benefits in insulin resistance and leptin levels. Here's a different study published in a renal journal. Here we have treatment hypertension in obese patients. Here's the reduction in systolic and diastolic blood pressure, and also subdivided by diabetes versus non-diabetes. And what basically you can see is that the percentages reaching blood pressure control, comparing the diabetics, and bear in mind that the diabetics have a different target blood pressure, and I mentioned this earlier, under 130. The non-diabetics is under 140. If you go by the 140, you see actually a fairly decent proportion getting to achieving to controlled levels by the 140 definition. In diabetics, a smaller proportion in terms of adding in moxonidine to these obese, non-controlled hypertensive patients. So resistant hypertension, I talked about diabetes. What about aging? And of course, all of us, as we all get older, sad to say, our blood pressure goes up as well. And this is, and among that table for resistant hypertension from the European guidelines, age does feature prominently. And with moxonidine, this is age under 65, age above 65, and the fall in systolic and diastolic blood pressure in orange and blue respectively, you can see is fairly comparable in this study. And this is just a, to put into more context. This is one of the these are data from the local blood pressure clinic in Birmingham where I used to practice, focused on elderly patients. And this was using ambulatory blood pressure readings. And this is for systolic and this is for diastolic. And I think you can see it's pretty clear that pre and post, this is the mean ambulatory systolic, mean ambulatory diastolic in elderly patients where there was this reduction clearly for systolic, reduction for diastolic, which was significant. And hence re-emphasizing what I've been mentioning, that how moxonidine would be very useful as add-on therapy in these elderly patients where hypertension is poorly controlled despite treatment with 2 or more drugs. And this is back to the table for so-called resistant hypertension, where elderly patients are thought to be problematic. Well, here's one option again that you can try and help to get better in these patients. Now, I briefly mentioned insulin sensitivity. And of course, this is relevant to diabetics, those patients with impaired glucose tolerance. And I think this slide nicely shows this is a cohort of mildly hypertensive patients. And if you will see that in terms of the insulin sensitivity on metformin, this is baseline, and then this is after treatment, as you can see there. Sorry, baseline is the solid line there. The dotted line is metformin at the end of the study. And you'll see here for moxonidine, that's the baseline and then the final. The curves are not that much different between the moxonidine and metformin. And metformin, of course, is a drug that is used in patients with diabetes and impaired glucose tolerance. And it's a sad fact that, of course, these risk factors are not in isolation. The diabetics very often may well be obese as well. They may well have insulin resistance as well, and as well as hypertension. And this is a observational cohort. It's post-marketing surveillance. And the overall cohort is the first groups there, as you can see. Then we subdivide Dr. Sharma subdivided by metabolic syndrome, yes, no, subdivided by severity of hypertension. And then I think it's fair to, this is the systolic blood pressure reduction, the diastolic blood pressure reduction. Here we are looking at in relation to weight. This is so normal weight, overweight, and grades of obesity, and for both systolic and diastolic. And I think the conclusion from this work is that moxonidine, this is the reduction compared to baseline, and I think it's pretty clear, irrespective of metabolic syndrome, irrespective of severity of blood pressure, irrespective of obesity status, moxonidine did effectively reduce blood pressure in the patients with metabolic syndrome, as well as reducing body weight in the obese patients. Now, this is to flag up. Well, one treatment often given even in diabetic patients is a beta blocker, and this relatively small study says why it may not necessarily make good sense, because this is comparing moxonidine, metoprolol on blood pressure and metabolic control. And as you can see here, this is well, firstly, this is systolic blood pressure. This is diastolic blood pressure. Yes, there's a reduction in blood pressure in both moxonidine and metoprolol groups. But what you see here is that moxonidine, unlike the metoprolol treated patients, moxonidine treated patients had beneficial adaptations in glucose. You see this beneficial, this is going in the right direction, whereas metoprolol is going in the wrong direction. moxonidine, and I haven't shown the data here, also had beneficial effects on lipids and in the hypertensive patients with type 2 diabetes. So it's the metabolic advantages by using moxonidine as add-on therapy in these high-risk groups of patients. And in a sense, this relates also to patients with metabolic syndrome. This is a relatively large study where looking at moxonidine and blood pressure control, whether it's monotherapy or in combination therapy, there was a significant improvement in blood pressure control. There was also beneficial trends in metabolic indices, including lipid fractions, plasma glucose, and moxonidine also was associated with a reduction in body weight. And lifestyle changes, including body weight reduction, is therefore is also part of the treatment goals for hypertension. I'm just going to finish off with another group of patients quite close to my heart, which is atrial fibrillation. And there are a couple of interesting studies showing how central sympathetic inhibition seems to have beneficial effects in some cardiac arrhythmias, such as atrial fibrillation. And don't forget, I mentioned earlier that atrial fibrillation you can regard as another manifestation of hypertensive target organ damage. Now, this is a small study, but it was hypertensive patients with paroxysmal atrial fibrillation who underwent catheter ablation. And in terms of 12-month recurrence rate, these are controls, that's moxonidine. I think there's a pretty clear difference between the two groups of patients in this randomized trial. And if you look at a Kaplan-Meier curves, again, moxonidine-treated patients compared to placebo, a benefit in favor of moxonidine in these patients with regard to recurrences of AF after catheter ablation. And this beneficial effect does not seem to be related to the antihypertensive action of moxonidine. The same group, this was a group from Greece, they were looking at treatment, at AF burden in hypertensive patients with continuous monitoring. And relatively small study again, but as you can see in the moxonidine-treated patients compared to placebo, a reduction in favor of moxonidine in terms of arrhythmia burden. And in terms of symptoms score based on the ERAS score, this was actually also improved with the reduction in arrhythmia burden in favor of moxonidine-treated patients. And like the preceding study, systolic blood pressure was not really that significantly different, but diastolic blood pressure was a little bit lower. So moxonidine in AF patients from the previous study showing a beneficial effect in terms of AF recurrences after catheter ablation, and in patients with paroxysmal AF in terms of reduction in arrhythmia burden and also reduction in symptoms when managing AF patients. So just to sum up and conclude with regard to the data on moxonidine, and this is hopefully to complement some of the earlier presentations with regard to resistant hypertension. In terms of the molecule, it is a centrally acting antihypertensive drug. It does decrease peripheral vascular resistance through the inhibition of sympathetic activity. And in terms of the efficacy, it's broadly similar to, for example, ACE inhibitors, thiazides, atenolol, and nifedipine, which very often are used in practice as first-line agents. Now, moxonidine has not been a primary intervention in large, big, huge, multi-center international randomized trials, but I think it's probably a very good place as add-on treatment to try and achieve the blood pressure targets that we've been discussing earlier. Centrally acting drugs also have attracted a lot of interest because of the spin-off benefits, particularly on metabolic effects. I think they are very useful options in patients who are difficult to control blood pressure. So just to conclude, moxonidine is a good option in terms of treatment of patients with mild to moderate hypertension, and also in adjunctive therapy, especially in the elderly patients, the diabetic patients, the patients with metabolic syndrome or impaired glucose tolerance, because you get the added benefit effect. And based on a couple of small studies, you could even postulate it might be good in another manifestation of hypertensive target organ damage, which is atrial fibrillation. And with that, thank you for your attention, and very happy to join the panel discussion and questions and answers.
Thank you, Professor Lip. That was a wonderful discourse on the guidelines for management of hypertension, and especially the later half about moxonidine, its role in management of hypertension in general and resistant hypertension in particular, and emphasizing upon its benefits with regard to metabolism, the insulin sensitivity, and of course, recurrence of atrial fibrillation, which are of course of great interest to we cardiologists. I think we do believe that apparently resistant hypertension is a huge, big issue in India. And I would be, in tongue-in-cheek, I would like to say that this problem in our country is as big as population of Great Britain, and based on the data available. And so that is why we are here discussing this apparently resistant hypertension. I know you said true resistant hypertension probably less than 10%, but apparently resistant hypertension probably 20%. And if I take 130 by 80, then we have a number which is close to the population of Great Britain. Thank you very much. Great talk, great insights into this molecule moxonidine, which of course our sponsors would be very pleased to listen to, and they would of course like to understand our personal experiences with regard to use of moxonidine. And I will give it to Dr. Amit Kamra to take the presentations further, the discussion further. Dr. Amit Kamra.
Thank you, sir. May I invite Dr. Soumitra for the panel discussion, please?
Okay, Dr. Amit. Thank you, Dr. Mohan, and that is a great presentation, Dr. Lip. We have got a short panel discussion, very objective few questions, and I will expect very brief and to the point experience sharing from the panelists, so that we can take up a few questions from the delegates at the end of our discourse today. But before I start, Dr. Lip, may I ask you, in your clinical practice, how do you position moxonidine in your day-to-day practice, particularly when I inform you that in India, prazosin is a very interesting drug and very commonly used, prazosin, even as a second line, third line. So how do you place moxonidine vis-a-vis prazosin?
I think that's a great question, and the European guidelines and the NICE guidelines in the UK actually have many similarities. So the sort of algorithm that I presented on earlier slides are very much commonly used. In my hypertension clinic, we very often start off with ACE or ARB, in especially those aged under 65, and then calcium channel blockers or diuretics in the elderly as the initial drug treatment. Then after you have that after combination. If you look through the NICE guidelines, it used to be ACD sort of combination treatments. Now, the challenge in having a specialist hypertension clinic, the system in UK, of course, is many are managed by primary care physicians or general practitioners. Once they start scratching their heads and getting to problem about blood pressure not reaching to target or the patient getting side effects, that's when they refer to us in the specialist hypertension clinic. So when they refer up, very often these are patients not getting to target, they are manifesting evidence of target organ damage, or they're not getting blood pressure control despite multiple drugs. And the other category is the young patients that get commonly referred to the hypertension clinic. Now, if it is resistant hypertension, then we make sure obviously that they are adherent and compliant lifestyle type changes, they're on the appropriate combinations. And bear in mind that, there's no drug with zero side effects. Very often in the hypertension, especially hypertension clinic, we do have to think about third line, fourth line, etc. Spironolactone or mineralocorticoid receptor antagonists have gone up the treatment algorithm in the ESC, in the European and the NICE guidelines, but after that, things like alpha blockers, things like moxonidine are certainly the next add-ons. UK prazosin is not so popular. Doxazine, which is also generic, is a much more popular of the alpha blockers. Alpha blockers are also a reasonable add-on drug. Now, a common side effect, not commonly volunteered by patients, by female patients, is incontinence with alpha blockers. It's a sort of side effect they don't volunteer unless you ask them. Now, men, especially who have prostatism, they certainly don't mind prazosin, or they don't mind doxazine. But female patient hypertension, they don't necessarily volunteer a relatively common side effect of incontinence. Moxovas, as I said, I quite regularly use it in the difficult to control hypertensives, and I've shared some of the evidence-based data for that. So it's good add-on, especially elderly, if they've got some evidence of impaired glucose tolerance, or if they're obese as well, and generally reasonably well tolerated. And I think, like one of the slides I put, the main side effect, if they do complain, is some dry mouth. But if you warn the patient before that, is usually tolerable and not a big problem.
Thank you, Dr. Lee. Particularly when the ALHA trial showed that increased heart failure with the prazosin group of patients and was withdrawn, I think prazosin is used a bit too much, and that should be replaced by more safer centrally acting sympatholytic like moxonidine. That is my personal take. Now I go to the panel discussion, and let's see. The first question is for our esteemed faculty here, Dr. Sadhanand Shetty. Resistant hypertension is a growing prevalence in India. Do you see an increasing trend of resistant hypertension in your practice, and how do you handle it, Dr. Shetty? Dr. Shetty, are you with us?
You can hear me?
Yes. Yes, I can hear you, Dr. Shetty.
Yeah.
Yes.
Thank you, Soumitra, and it was an excellent session we had from the beginning. And most of the topic, even in the QA, are discussed during our talk by Dr. Gregory, Dr. Mohan, and you. Of course, as you have shown in your Indian data, is about at least 20%, and what Gregory shown in the incidence is about 10% after excluding probably the pseudo-resistant causes, etc. But it is one of the practical problem in our day-to-day real-world practice, and possibly it is increasing, possibly because of the few factors which Gregory showed, which I think is very, very applicable to us actually, like the elderly age group, maybe the obesity is also on the increase, and we have this metabolic syndrome and comorbidity like diabetes and the CKD, etc. So essentially, it comes to the treatable options what we have, and considering that, and what molecule what we are talking about, moxidine, according to me, is is sort of probably in India is underused. Most of the Gregory's data and almost the presentation of 2005, 2006, even the Mercy data of 2014. But in spite of the data, if you see the progress in this drug usage, is not that much what I think my personal experience was. I also totally agree with Gregory of use of this molecule in our day-to-day practice, at least in the subset of like a resistant category after particularly when you got the early CKD, or people cannot tolerate the ACE or ARB due to some reason, or you start ACE ARB, then we have to step down because the rise of creatinine. At that stage, again, moxidine is useful, and things like that. So definitely resistant hypertension is on the increase. I agree with that, Soumitra.
Thank you, Dr. Shetty. So it appears that you are getting a large number of resistant hypertension, and perhaps the best solution you were suggesting is to whatever the 2 or 3 drug combination patient is getting with the breakfast, you add a moxonidine type of drug at bedtime. That will solve many of your problems and will take care of the extra metabolic syndrome part as well. That's great. Now let's go to the next question. Dr. Lee, please.
No, I just wanted to
Yes,
make a brief comment on that previous discussion about whether resistant hypertension is increasing or not, and I think it's just to. And this is a bit of a problem we've got with some of our local general practitioners. They're quite ready to label somebody as resistant hypertension, but I think it's also equally important we carefully evaluate, and particularly adherence and persistence with their treatment. And certainly one option practiced in many specialist hypertension services is to be able to actually check the urine drug levels, just to make sure that they are actually taking their tablet. We try and do it random so that the patient doesn't know that they're coming to clinic, that they're going to take the tablet in the morning before the clinic. So it's just random, because the patient sometimes comes in on 6 or 7 drugs and they say, oh, I take my tablets, religiously. Then actually you do the urine, drug level, drug testing for the antihypertensive drugs undetected, and they're obviously not compliant.
I agree with Gregory. Brian William, many times during his talk, one of the common thing, at least in your country, UK, is doing the urine level of the drug just to see with the patient. So therefore, possibly what you showed, less than 10%, ruling out all those whatever pseudo so-called adherence, etc. Yeah. So that point is
actually you get something. Actually, you can get something extra, which is very peculiar to India, Dr. Leap. We many of our population take the unknown substance, which are given by some specialty doctors of homeopathy and other specialties. The drug is supplied from their clinics in a packet without any labeling, and most of them contain steroids and stuff like that. So that is another very important thing we should exclude when we are facing resistant hypertension. So next topic is your clinical practice, which patient types are best studied for moxonidine? Dr. Shafika, would you like to take it first, followed by Dr. Leap?
Yeah. So in my clinical practice, of course, I see patients with CKD or renal disease. And as I already told you, most of the patients are on multiple antihypertensive drugs, maybe 3 or 4 drugs at one particular time. What I find is that if I have some difficulty in using a particular class of drugs, for example, with calcium channel blockers, patient is developing edema of feet, and the patient has got a kidney disease, difficult to make out what is happening as far as the progression of edema is concerned, then that would be a situation where I might replace one drug with the other. Same thing is true with use of ARBs with the rise in creatinine, or with alpha blockers. There's a great postural drop of blood pressure. In those situations, I think moxonidine is a add-on, especially if you run out of drugs because of side effects. In that case, obviously, you need a drug with lesser side effects. And I personally believe that there are some patients who respond differently to different drugs. So for example, every person is not going to respond to a particular drug in the same way. So therefore, you might have to change and then decide what to do.
Dr. Shafika, do you add beta blocker with moxonidine? Is it a good combination, or is there any contradiction between the two?
No, there is no real contraindication as far as addition is concerned, but the indications for beta blockers are fewer as compared to the other drugs as far as control of blood pressure is concerned. So therefore, unless the patient has got a heart disease and the patient requires a beta blocker, then of course there is no problem in adding moxonidine at all.
Dr. Leap, in your experience, what is the incidence of postural hypotension with moxonidine?
Don't see it so much with moxonidine, certainly see it with alpha blockers, and especially in elderly patients. It's very often they come back to the next clinic appointment complaining of dizziness, and actually if you check the blood pressure, especially the elderly patients on an alpha blocker, it can be a problem. Now moxonidine don't really see that much. And in terms of your prior question, although at the start you did ask me the groups of patients that I that I also focus. It's just to again make a plea. I mean, I run the hypertension service in our tertiary center hospital, but the other service I run is atrial fibrillation as a clinic, and is to remind our audience it's that very often patients have multiple comorbidities. So atrial fibrillation patients very commonly have hypertension, they have a degree of renal impairment, they have diabetes, they have metabolic syndrome, they have sleep apnea. All these things really have to be put into the wider context and all managed. You don't manage a bit of the patient, you manage the whole patient.
As I mentioned at the beginning, sir, what is your, how concerned you are of falling diastolic blood pressure while controlling systolic blood pressure?
I think if you look at this epidemiologically, the main determinant of CV risk or CV outcomes is largely systolic, even though you account for the diastolic blood pressure in your particular patients. It's quite interesting because if you look to the historical blood pressure trials, and one my presentation I touched on one or two of them, they actually use diastolic blood pressure as their efficacy outcome. More contemporary trials, they have clearly also looked at systolic blood pressure, recognizing the stronger association with CVD events and stroke related to systolic blood pressure. So when I measure the in my hypertension clinic, it is to re-emphasize the point that patients and general practitioners, because UK practice at the specialist clinic, we communicate instructions to the primary care physician. They like things very simple, and I suppose in the last year in the COVID times, very much some of the patients were even taught to measure their blood pressure, and with a virtual outpatient clinic, when you phone the patient, is to keep it simple for them as well. So I certainly used to tell the patient the more important is the systolic blood pressure, and not to get too obsessed about diastolic blood pressure. And certainly the technology is obviously evolving, and if you look at some of the more automated blood pressure machines, the systolic clearly is is at least measured reasonably accurately. The diastolic in some of the older automated machines are as based on an algorithm rather than the actual diastolic. So I focus more on the systolic blood pressure. So I'm not too obsessed with the diastolic blood pressure.
Thank you. Dr. Mohan, now how convinced you are about these pleiotropic benefits that we have heard with moxonidine?
Let us first concentrate on the fact that moxonidine is a reasonably effective fourth-line antihypertensive drug in certain patients, especially those who are CKD, especially those who have diabetes and tendency towards hyperkalemia, and who have not responded to ACD, including, of course, spironolactone. The anti-proteinuric benefits, weight reduce, increase in HDL, decrease in LDL, improving insulin sensitivity, all something which we have talked about. These, of course, do weigh on my mind when I'm using moxonidine in a given case. But these are not the primary reasons I'm using moxonidine for management of resistant hypertension. My point remains, wherever I can't use spironolactone at fourth place, I will use moxonidine. If for some reasons I can't use moxonidine also, or I'm not seeing benefit with moxonidine, I can't use spironolactone, I'll definitely go to, as you rightly say, prazosin or maybe bisoprolol, as the pathway 2 study showed. Having said that, 20% of my practice at the moment has moxonidine because I do not see run-of-the-mill hypertension. I only get people who are relatively resistant hypertension. People can't afford to pay my fee actually just for management of hypertension. So they have to come when they really are unable to control it. I am convinced that there are pleiotropic benefits. These may be doing something. I have no outcome data actually, so I can't say whether these pleiotropic benefits are actually weighing on my mind when I'm choosing moxonidine. Certainly, I wouldn't say that, but I'm little convinced better that anti-proteinuric benefit and anti-dysglycemic benefit, and of course, some of the lipid favorable benefit. I'm probably doing some good to my patient when prescribing moxonidine as an antihypertensive drug, knowing it is a modestly effective antihypertensive drug is no great. And the kind of data which has been shown by Dr. Lip, we don't see in our practice. Once we have given all three antihypertensive drugs, you see about 8-10 millimeter fall in systolic blood pressure, about 4-5 fall minute diastole, which is acceptable because that will cut down the risk by another 20% in case it persists.
But Dr. Mohan, we have got in India 0.2 and 0.3 milligram of moxonidine. But most of the trials Dr. Leap showed was 0.4 milligram moxonidine. So how do you compromise? Do you give 0.2 milligram twice?
So 80% time I use 0.3 milligram twice a day dose, and I don't exceed it.
Twice a day?
I have tried to exceed the dose to 1.2 milligram. However, I think there is a ceiling effect. The blood pressure lowering effect does not come up beyond 0.6 milligram of the total dose, so I don't give it. I'm also aware of that MoxCon study by Carl Swedberry, which has shown actually worsening of heart failure, increased mortality in HFrEF patient when moxonidine 1.2 milligram was given with rapid up titration. And we have data to suggest that moxonidine increases the level of natriuretic peptides, although lowering norepinephrine levels. And it has been suggested that increasing natriuretic peptides by independently, actually, it might be actually increasing diastolic wall stress.
Dr. Lee, what is your usual dose of using moxonidine?
In UK and EU, moxonidine is available at 0.2, 0.4. And then if we go to the top dose, it's 0.6 as a split dose. So in that case, it's a 0.4 in the morning and 0.2 in the evening. So that's our usual practice. We don't have this 0.3 dose. So it's reflecting differences in what's available in different countries. I fully agree, Dr. Mohan. I mean, I don't necessarily, prioritize the particular pleiotropic type effects, because by the time you get to some of those categories of patients, you really need, they have multiple drugs, and then you're trying to, and some of those drugs have been causing problems or side effects or whatever, and it's nice to have an extra, drug possibility in moxonidine to add to these patients. Now, the spin-off pleiotropic effects, that's an added bonus, I think.
Thank you. Let's go quickly to the last question. Very quick answer from you, Dr. Shetty and Dr. Shafekar. How do you compare moxonidine with clonidine in your clinical practice? Dr. Shetty first, please.
Yeah. No, the experience is excellent of moxonidine. And side effect profile, as Gregory rightly showed, moxonidine is minimum, unlike the clonidine, because of its selectivity into the imidazolone 1 receptor, unlike the alpha-2, which clonidine has got almost, the good sort of, the alpha-2 receptor action also, unlike the moxonidine. And so dry mouth, if at all, is one side effect of moxonidine, unlike, all those drowsiness and other side effect of clonidine. Moreover, the withdrawal effect also is not that much with moxonidine because it's a little more longer acting than the clonidine. And that's one other advantage of this thing. And so these are the few things basically I would say. And between the clonidine and moxonidine, the difference between the receptor sense selectivity and the dry mouth is one side effect, unlike the clonidine, which is more, and the withdrawal, which is more with the clonidine. And then, the dose may be, as Gregory mentioned, in India, we have only 0.2 and 0.3. I have yet to use BD dose. I have not yet written this, BD dose because it's an add-on drug like that. But only thing is how to make it more popular, that I don't know. That Gregory must tell us, because all of us, Dr. Mohan, Soumitra, we all have, even Chapekar, we have earlier met on this subject. I've written an article 2 years ago describing all the properties. And Gregory showed all the data of 2005, 2006, 2013, but still it is not that popular, at least in India. So there possibly we need Gregory's, and not many companies are marketing also. If I remember, hardly 2 companies or maybe 3, I don't know. But
Exactly.
yeah, so that
The market noise really matters.
That,
Yes.
Gregory, you have to probably put, because all our viewers and for the Indian company, how to make it, more popular, because a good drug and definite role in it. I say, personally, I say, when I can't use ACE, aldosterone blocker, as Mohan rightly mentioned, you fall back on moxidine, like insulin sensitivity, then your metabolic syndrome, then all those properties of moxidine minus the renal problem.
Dr. Shafekar, a quick word from you as compared to clonidine.
Yeah, so I think everything has been said. Only 2 points. One is about rebound hypertension. Sometimes when it is withdrawn, you do get rebound hypertension. And the second issue is about the postural drop. We see it more in diabetics with autonomic neuropathy, and especially if the intravascular volume is low. So these 2 points should be remembered when we prescribe moxidine.
I think we take some questions, and at the end we will ask the final word from Dr. Shetty and Dr. Mohan and Dr. Leap also. Very quickly, I'll take a few questions which are burning in the minds of our delegates. Actually, some have put the question even before the program started. Dr. Prakash Mohanty from Puri, what time of day antihypertensive to be given if hypertension is controlled with single drug? Is it more beneficial to administer combination of 2? Dr. Mohan, please.
Well, we know that these questions started coming in a big way after HiGEA study was published 2 years back by Raymond Hermida. We are also aware of a very properly conducted randomized study by Neil Poulter, which showed that morning or evening dose, the difference between decrease in blood pressure is less than 2 millimeter of mercury with the same drug, indicating it doesn't make a difference as far as the blood pressure is concerned, whether you give morning or the evening. A big randomized study time is going on, which will try to answer that question.
Thank you. And of course, 2 drug in lower dose is better than 1 drug in higher dose. That is now accepted by all authorities because you are getting complementary action and keeping the side effects low. These are the 2 basic points. Now, the next question coming from Dr. Amit Saxena, Bhopal, I think it's already been answered. Moxonidine may be used with other antihypertensive molecule like amlodipine. Yes, Dr. Leap has shown enough data that it should be a combination because it is never a first line, so already medicines are on board. Dr. Jia Ahmed from Srinagar, how effective is renal denervation in resistant hypertension? Now, Dr. Shafekar, very quickly, after Simplicity 3.
So a lot of controversy about renal denervation. It's trying to come back now. I think the problem was related to the operator and the devices which were used. But now I think it might come back. And yes, it is beneficial in a very selected group of patients. And it can be tried when all the other drug therapy has failed. But it should be done at proper centers. But
we must say that it is still experimental. It is still experimental in the research domain and not yet approved by DCGI for common use. So that we should keep in mind. Dr. Pankaj Kashyap Badua from Jorhat. Sir, may I once again get the dose schedule, when to start Moxovas with ARB and when to leave ARB? Dr. Shetty?
Yeah, as I mentioned, one of the important, it's a good question actually. I don't know, Gregory also may need some help from him. What has been mentioned, what we do, at least my personal take on that, when I put on ARB and if at all, there's a more than 30% rise of, the creatinine, and now, I can't step up the dose, maybe I may have to get down, but I need also the blood pressure control. Then at that stage, in fact, moxidine, come in the right place actually, This is what is one of the time when both moxidine and RAS blocker, because see, we want to take the positive benefit of RAS blocker also at the same time control of blood pressure. I don't know, Gregory may have some the clinical experience of this situation. This is what at least my personal take on that.
I think you sum it up very nicely. I mean, we very much follow the ACD algorithm in terms of initiation, and we try also, and this is relevant to the earlier discussion about how we we make this increase the awareness, and of course, as webinars and educational sessions such as this will hopefully help that. But in the patients who are intolerant or they get side effects with some of the first line agents, then you go on to other agents to try and get the blood pressure down. One of the messages you flagged up with regard to the rise in serum creatinine, because certainly it's more our primary care physicians who probably press the panic button a little bit faster than us in hospital. As I say, I'm prepared to sort of carefully watch the serum creatinine or the estimated EGFR just to following the introduction of particularly multiple hypertension drugs. And do bear in mind, my hypertension service, we are getting all like we're getting the resistant or rather the difficult hypertensives coming to the clinic. So I haven't I don't think I've really seen a lot of ACE-ARB discontinuation on the basis because we've been trying to educate them, don't press the panic button so quickly. But if the renal function does deteriorate quickly, it also is a good pointer to renovascular problems, whether there's renal artery stenosis or something like this. And certainly in the last year, I've picked up a few with renal artery stenosis, and actually it wasn't because of renal function deteriorating. It was just because they were referred up from other cardiologists on about 4, 5, 6 drugs, and my other cardiologist colleagues are wondering why was it so difficult to control the blood pressure. And after the proper workup, the thing we picked up was renal artery stenosis.
True. Now, maybe the last question as we are ending, that taking example from the diabetic and the dyslipidemia field, now it is an aggressive management and quicker control. How long do you wait between the steps of a fixed dose combination of 2 drug, 3 drug, and then adding the 4th or 5th drug? How long do you wait in between? Dr. Lip?
Well, I suppose I'm in a healthcare system which is supposedly having shared care with the general practitioner. So the patients would be given an instruction that the next to go after the initiation of the new agent or change in the drug therapy, to attend the general practitioner usually within 2 or 3 weeks to get how the blood pressure is responding. I always encourage my blood pressure patients to keep a blood pressure diary. Now, this can range from just a notebook with like a diary to get all the blood pressures recorded, or increasingly we also see the more tech-savvy patients putting it on their phone, and then they come to the clinic, they show me the phone, or they send an email with the phone to my secretary. So you do get, and there's a lot of good data now for home blood pressure monitoring, as long as the patient's informed how to do that correctly. And then the next visit, very often after that intermediate visit with the GP, is back to me in the clinic, and I would have then seen the patient probably 2 months since the first meeting, because I've seen the patient, and then the next visit is with the GP, hopefully also with the home blood pressure readings. Then the next visit comes back to the specialist clinic. The GP in the letter correspondence is instructed, if they're not responding to the first drug, what's the next option, or whether the dose can be increased, or whether you add the next add-on therapy. So a management plan is very often given when I see the patient for the first time. If at the intermediate visit the GP is struggling, very often we get a letter back or an email back saying that this particular patient, is not tolerating this new drug you initiated. The blood pressures are still not coming down. What's your next option? And then, of course, then you bring back the patient early if necessary.
Generally, it is about 4 to 6 weeks before you change the regime or increase the regime.
Yeah, that's a reasonable time, yes. And also re-emphasizing the lifestyle type changes, which are very important in hypertensive patients.
Yes, yes. So I think we are coming to the end of the program. Dr. Mohan, do you have your last word and word of wisdom to our delegates for tonight?
My definite feeling is that in this country, moxinidine is an underutilized drug. That's number one.
Yeah, there's one. Yeah.
It is a relatively safe drug. And at fourth level, at fourth step or fifth step, it is pretty good drug with barring the dryness of mouth, we haven't seen any significant. However, we also have to keep in mind that it has a modest efficacy when given after ABC. When given after ACD, it has a modest efficacy, but nevertheless, even that efficacy is acceptable. Do not give this drug simply because there are pleiotropic benefits, but those are add-ons whenever these drugs are required. However, compared to beta blocker, I will use moxinidine more often. My personal experience is that in resistant hypertension, moxinidine works better than beta blockers. And my last point would be that CKD patient, I preferentially would use it over and above spironolactone and beta blockers because I'm convinced that the drug has two additional properties: direct natriuretic benefits, not necessarily because of decreased sympathetic outflow, but some studies have shown direct anti-natriuresis neutralization, and of course reducing the proteinuria. So those are two things which convince me about using it more often. All in all, I would say it is a good addition to our therapeutic armamentarium to be used in about 1/4 or 1/5 of apparently resistant hypertensive individuals.
Very clear message, sir. Thank you. Dr. Shafekar, your last word, very briefly.
Yeah, I think it's a useful drug. For nephrologists, I think it's a boon because we run out of drugs because of side effects. So I think it should be remembered. Right patient, right dose, and the right time. I think that's the message.
Only one.
Shetty?
Yeah, I just want, because every time, discussion of Moxovas, I'm disappointed because, the growth of this is not occurring in India. So maybe the company guys can give us what is the growth of these APIs. As Dr. Mohan rightly mentioned, this one molecule is underused, and that's why I asked Gregory also how to make it, webinar, knowledge sharing is fine, but what is the growth of this molecule from the time it is, introduced and now, at the moment, current moment. Maybe the company guys can give us some information.
I think the emphasis should be to replace that prazosin, the mini-press XL, which takes so much of market unnecessarily by moxinidine. So it is my clear message to the company that replace mini-press XL by your moxinidine, which is a far better option for your patients. Dr. Lee, what is your last message to India regarding this issue?
Well, I think this has been a fascinating panel discussion. The message, I think, has been flagged up by many colleagues. Is important to, especially if we are focused on the so-called resistant hypertension. Don't be too ready to label somebody as resistant. Make sure that we make sure we evaluate the patient carefully, make sure that we don't miss any secondary causes, make sure that we are aware about the adherence and persistence with drug therapies, and then make sure that we use sensible combinations. And as the goalposts are moving towards blood pressure targets, especially in the presence of target organ damage, we will inevitably need to fall back on the third line, fourth line, fifth line drugs to try and reach those blood pressure targets to improve our care for patients.
Thank you. So I stop over here, thanking all the faculty and especially our international faculty, Dr. Gregory Lee. And now the mic is back to Amit Kamra. Dr. Kamra, your last word, please.
Well, thank you so much indeed. On behalf of Moxovas Pharmaceuticals, I would like to thank all our audience for their patient listening. And I'm sure that the learnings that our audience has will transform into better clinical practice and translate into improved patient outcomes. We definitely have our takeaways in terms of blood pressure control and multiple pleiotropic benefits. Thanks to our esteemed faculty, Dr. Lip, Dr. J.C. Mohan sir, Dr. Shetty, Dr. Ray, and Dr. Chafekar sir. And wish you a nice evening ahead. And thank you very much.
Thank you to
Stay
everyone.
safe, all of you.
Thank you.
Yes.
Stay safe.
Thank you, sir.
Thank
Thanks and take care, sir.
Thank you and
Take
bye-bye.
care.
Bye-bye.
Thank you, sir. Thank you very
Thank you.
much
Good
all.
day, sir. Good
Okay.
night.
Bye.
Thank you, sir.
Thank you. Thank you. Yeah,
It was
hello.
a nice session, sir.
The question and